Good morning, everybody. It's my distinct pleasure to be here today to talk to you about the PCI updates as it relates to the revascularization guidelines. I don't have any conflicts of interest to disclose. So unfortunately for you, I cannot talk to you about the PCI updates in the revascularization guidelines because the revascularization guidelines for 2021 have not yet been published. Instead, what I'd like to do is to talk to you about the practice-changing clinical trials that have been published over the last 5 to 10 years, and to sort of highlight to you the things that have changed my own personal way in which I approach patients with coronary artery disease undergoing PCI. So as you can see here, there's been many trials related to PCI published over the last 5 to 10 years. Unfortunately, I don't really have any time to focus on all of them, but I will focus on the trials related to multi-vessel PCI and STEMI, the radial artery access trials, and the trials looking at different DAPT regimens. So let's start with radial artery access. And what I'm going to talk about is the MATRIX trial, which was the largest of all of the trials looking at radial artery access in patients undergoing PCI. In the MATRIX trial, they randomized over 7,000 patients with ACS to a strategy of radial artery or femoral artery access. And in this trial, approximately 80% of patients who underwent coronary angiography received PCI. This trial had two co-primary endpoints. The co-primary endpoint of death, stroke, or MI at 30 days was just short of statistical significance with a p-value of 0.03, but showed a lower rate of outcomes with radial artery access compared to femoral artery access. The second co-primary endpoint, which was a composite of MACE and BARC3 or 5 bleeding at 30 days, was significantly lower with radial artery access compared to femoral artery access. And in the MATRIX trial, there was a lower overall mortality with radial artery access. This trial was consistent with other trials, which definitely showed lower bleeding with radial artery access. And the meta-analysis of trials showed overall lower mortality with radial artery access in patients with ACS. So what's my own personal perspective? Well, I certainly prefer radial artery access, and I would advocate that if you can, you should really try to transition to radial artery access, because I certainly think it results in less access site complications, lower rates of bleeding, and potentially lower major cardiovascular events in patients with ACS. I would say that femoral artery access may not be as bad as the clinical trials depict. And so therefore, if somebody is really strongly doing femoral, I would not advocate that they switch to radial artery access to do their first radial artery case as a STEMI case. I would say you should take your time and learn to do radial artery access over time and save your STEMI and your ACS cases for when you feel comfortable doing radial artery access. On the other hand, if you are a radial interventionalist, I would also advocate that when you do femoral artery access, you definitely remember to use safe femoral techniques. Let's talk about multi-vessel PCI and STEMI. So I'm going to focus on two trials, the CULPRIT trial and the CULPRIT trial. The CULPRIT trial looked at over 4,000 patients with STEMI and randomized them to a strategy of multi-vessel PCI performed as a staged procedure or CULPRIT lesion-only PCI with PCI of the non-infarct artery only for symptoms of refractory ischemia. In this trial, there were two co-primary endpoints, cardiovascular death or MI, and cardiovascular death, MI, or ischemia-driven revascularization. And in this trial, there was a significantly lower event rate with complete revascularization performed as a staged procedure compared to CULPRIT-only PCI. This trial was the only trial that really showed a lower rate of hard cardiovascular endpoints, including cardiovascular death or MI. Now, on the other end of the spectrum, in the CULPRIT-SHOCK trial, the investigators randomized over 700 patients with cardiogenic shock, acute MI complicated by cardiogenic shock, and randomized them to a strategy of CULPRIT lesion-only PCI versus doing all of the vessels that had severe disease at the time of the PCI, the CULPRIT lesion PCI. In this trial, the primary endpoint, which was a rate of death or need for renal replacement therapy at 30 days, was significantly lower with CULPRIT lesion-only PCI, indicating to us that in patients with shock, perhaps the strategy of only focusing on the CULPRIT lesion is superior to a strategy of doing all of the severe lesions in patients with multivessel disease. So my own personal perspective on all of the trials of multivessel disease in patients with STEMI is that we know that multivessel PCI in STEMI is safe. And I personally prefer to do multivessel PCI in patients with STEMI as a stage procedure rather than at the time of the primary PCI. Multivessel PCI as a stage procedure has been shown to decrease hard cardiovascular events, including cardiovascular death or MI. I personally avoid doing routine multivessel PCI at the time of primary PCI in my STEMI patients who have cardiogenic shock. But the most important thing is that we need to individualize care. In somebody with shock who has an uncertain culprit lesion or who has a very ulcerated or slow flow in a non-culprit lesion, I might do multivessel PCI at the time of the primary PCI. On the other hand, in a stable patient with STEMI, who I performed a successful primary PCI, I might choose to do an ischemia-guided approach if the artery supplies a small area of myocardium, or if the patient has other multiple comorbidities. So I think we really need to individualize care in our STEMI patients. I'd like to finalize this talk to briefly talk about DAP regimens. As we know, the new kid on the block is looking at a shorter duration of DAP followed by P2Y12 monotherapy. And the TWILIGHT trial was one of these trials looking at a shorter duration of DAP. And in this trial, they randomized patients, over 7,000 patients, to a strategy of shorter duration DAP followed by ticagrelor or monotherapy compared to usual DAP for 12 months. The primary endpoint, which is BARC 2, 3, or 5 major bleeding, was significantly lower with a shorter duration of DAP followed by P2Y12 monotherapy compared to usual DAP for 12 months. When looking at ischemic events, a shorter duration of DAP was not inferior to standard DAP in terms of the rates of major adverse cardiovascular events. So taken collectively, I would say that there are myriad antiplatelet regimens that we can use for patients undergoing PCI, with shorter duration of DAP followed by P2Y12 monotherapy being one of the many regimens. I think the shorter duration of DAP followed by P2Y12 monotherapy is very reasonable, but I would definitely advocate for individualized care in all of our patients, trying to balance a patient's ischemic risk with their risk for bleeding. So we are hoping that the coronary revascularization guidelines will be published by the end of quarter 4, 2021. And all I can say to you is, with respect to what the overall revascularization guidelines say and the whole writing committee's perspective on PCI updates, please stay tuned.